This session will spotlight the healthcare attachments for claims and prior authorization. Lynn and Sherry will share early adopters' experience with the X12-275 transactions and the embedded HL7 C-CDA. In addition, they will share their experience with the X12-277 healthcare claim request for additional information. Immediately following this session, we'll be once again breaking into our stakeholder groups, and we'll be proposing a couple of questions for you guys to discuss amongst your group. My pleasure to introduce Lynn Bushman, Agile Product Manager with the National Government Services, and Sherry Wilson, Executive Vice President, Chief Compliance Officer with Jopari.
Thank you, Michael. Good morning, everyone. First, a big thank you to Weedy for inviting Sherry and myself to speak to all of you today. We're really excited to share all this information with you. And we are going to talk about electronic attachments and our implementation, just as Michael had mentioned. The agenda for today is we're going to talk about why we implemented electronic attachments without that federal regulation. We're going to give you a little bit of history and then the evolution of where we are today with attachments. We're going to talk about an unsolicited and solicited workflow examples. And then, of course, we want to share our successes and lessons learned with you. So first of all, why did we implement electronic attachments without that federal regulation? Well, there were many reasons why. First of all, that manual process, very time-consuming and very costly, right? Everybody realizes that. It's that way for the payers, the providers, as well as the clearinghouses and the vendors. With the electronic solution, it increases productivity and eliminates a lot of those manual tasks. So lots of pluses there. The manual process impedes workflow automation, right? Requires more appeals, and it impacts the provider's revenue cycle management, their money, right? They don't get paid as fast. With the electronic solution, it's an automated end-to-end workflow process, and there are audit controls at every touch point. So a lot of efficiencies built in with the electronic process. The manual process is inconsistent, right? From payer to payer, provider to provider, the processes are different. With the electronic process, the transactions are standardized, right? So the processes are a little bit more standard between the providers and the payers. There's also a delay in patient care, and it drives the costs up and it impacts the healthcare outcomes. Excuse me. So as we know with prior authorizations, it's very important for the providers to receive that prior authorization response in a timely manner. If you're doing it manually, it's just really prolonged the time frame for them to receive the response from the payer. Electronically, it's expedited, right? So they get that response a lot quicker. The manual process, there's a lack of data integration between applications. So it's a manual process, so you can't really integrate it between different applications. When it's electronic, you can integrate it between those applications. The manual process is complex, right? Very cumbersome, as we mentioned. So with the electronic process, it's a little more streamlined and the business processes are more simple. There's a delay in receiving letters and documentation. So with the electronic process, there's definitely a savings with eliminating the mail. When the letters are sent by way of the mail, it takes several days, maybe up to 2 weeks for the provider to receive that. With the 277 request for additional information, that is generated and delivered the same exact day that the letter's generated in the processing system. So as you can see, it's going to eliminate that mail time frame. With the payers, with multiple payers, the workflow causes burden on providers. So as I said, each payer has different workflows with the manual process. With the electronic process, you're using those standard transactions, and it increases efficiency and it reduces that provider burden. I'm going to turn it over to Sherry to talk a little bit about the clearinghouse infrastructure.
Thank you, Mary Lynn. As a clearinghouse industry, we had already built the EDI infrastructure And really our challenge was, how do we leverage existing EDI framework to be able to support electronic attachments? So in working with our stakeholders, which included providers, payers, other clearinghouses, revenue cycle management, and other third-party vendors, we found various levels of EDI readiness really across the continuum from low tech to high tech. So we needed to develop flexible technology solutions to be able to accommodate these different readiness levels. But in addition, we also need to address the business barriers and the lack of critical mass. And we're able to do that by validating the stakeholder ROI and engaging industry collaboration by identifying synergistic opportunities. I think you heard some of that from yesterday's conference, and you'll be hearing more of that through our presentation today. Next slide, please. So today we'd like to share with you some background history of our experience and lessons learned in implementing the X12 275 and 277 RFI transactions. So with that, I'm going to turn it back over to Mary Lynn.
Thanks, Sherry. So going way back, right, I want to share just a little bit of history with you, and I'll get to the reason why I want to share it with you. Back in 2005, NGS participated in a proof of concept with Weedy, Memorial Sloan Kettering, Montefiore Medical Center, and NextGen. The pilot was for solicited attachments only, and that was because the providers who were participating in the pilot, their biggest pain point was when we sent them the letters, it took them a while. It took them several days to get it directed to the right person to respond to it. So they have different sites, different departments, different doctor's offices. So by the time the letter got, was received by the appropriate person to respond to it, their claim would be denied in our system, and they would have to request an appeal. So definitely it impacted, their payments. So that was a big pain point for them. So that's why they wanted us to pilot the solicited model. The results of the pilot, the proof of concept, it did resolve their pain points because they received that 277 request for additional information the same day the letter was generated. Because it was electronic, they were able to route it to the correct department, office, whatever, and they were able to respond in a timely manner where, we were able to pay them without them going through the appeal process. Out of that pilot, and these were the things that I really wanted to share with all of you, we did find some issues with the implementation guides, with the X12 implementation guide, with the HL7 implementation guides, as well as with the Medicare processing system. So because of those issues, we worked very closely with the SDOs, with X12 and with HL7, and the guides were corrected. So the things that were incorrect in the guides, we did get them corrected in future versions. And we also worked with the Medicare shared systems to include the necessary data. So for example, on the institutional letter, the patient account number wasn't there. And we needed that in the 277 request for additional information. And that was needed on the other end by the providers as well. So we did work with the Medicare shared system, and that has since been changed, and that patient account number is now on the letters. Fast forwarding a little bit to 2014, NGS is a Medicare fee-for-service contractor, and we were awarded the MAC J6 contract. So we did have some providers requesting that we implement the unsolicited model. So we did work with CMS. CMS gave us the approval to move forward with implementing in production the unsolicited attachment model. We did implement the X12 275 version 6020 with the embedded HL7. And we chose a version and also chose HL7 because at that point, X12 and HL7 had recommended those transactions, the versions, to the Secretary of Health and Human Services to be named in the attachment regulation. So we wanted to kind of prepare, hopefully, to see that regulation coming out and that we'd be in good shape when it did. The initial rollout of this implementation was only for our J6 Part B providers. We kind of wanted to start slow, see how it went before we opened it up to everybody else. But it was very successful. And because of the success, once we had several providers in production, we decided to open it up to our JK Part B providers, and then eventually to our J6 JK Part A providers. So fast forward a little bit more to 2018, we had providers request a solicited model. So obviously, there were still many providers out there who were receiving our ADR letters, our development letters, and so they still had that pain point. They still had that problem, that issue with routing those letters and responding to them in a timely manner. So we had providers who requested that we implement that. So we did implement the 277 request for additional information. Again, we went with version 6020 because that's what was recommended to the Secretary by X12. And this was implemented for both of our MAC jurisdictions, JK, J6, as well as Part A and Part B. So we implemented it for everybody. The provider's response to the 277, of course, we recommended that they use the X12 275 with HL7, but we also allowed them to respond in paper because we did have providers who were not ready to send the 275 yet. So we did allow them to send the paper. I'll turn it over to Sherry to talk a little bit about the clearinghouse history.
So from our experience, we really began attachments in 2008 with unsolicited attachments for property and casualty. And at that time, and still, property and casualty has a high level of associated attachments. So states began to mandate electronic attachments that were really TIFFs and PDFs. And then in early 2017, Minnesota Workers' Compensation mandated the X12 275 version 5010. And what we found from the provider community was that they experienced a lot of value to electronic attachments, and they came to us asking, well, this is working so well, how can we transition, healthcare attachments for commercial and government processing? And again, we took a look at that, and the opportunity came around at 2017 as well with NGS. So we implemented the unsolicited X12 275 version 6020 with the embedded HL7. And then based on the success of that program with NGS, we went on to implement the X12 277 RFAI version 6020. And again, building off of this and provider demand, wanting electronic attachment solutions, one workflow across all lines of healthcare business, we, through again collaboration, began to get engaged with other payer attachment programs. And that really led, again, to that key to begin to get adoptions and to remove past that barrier by having stakeholder synergistic value proposition and that collaboration. And to further drive that point home, I'm going to turn it back over to Mary Lynn to talk about the evolutions of attachments and where we are today.
Thanks, Sherry. So back in May at the Weeding Spring session, we presented on electronic attachments with several other payers as well as other clearinghouses. And we talked about these next two slides. We included these in our presentation back then. And what this shows you is the different payers and what they've implemented. So we did want to bring this up, show it to you that there are other payers who have implemented electronic attachments and kind of where they are, what they've implemented, if they implemented solicited and unsolicited models, if they included HL7, and the acknowledgements that they've implemented. So this slide is for claim attachments, and it shows you kind of that status. And then the next slide is for prior authorization attachment. So again, shows you which payers have implemented it, if it's on their roadmap, what the acknowledgements are, things like that. Now, these two slides will be available, of course, in this PowerPoint once it is posted out in Weedy, but also out in the from the May session. The slides should be out there as well if you're interested in looking at them. But we did want to show these to you and just show you where we are with where the other payers are as well with the implementation of electronic attachment. Just to take a step back for a minute, just want to explain the unsolicited and the solicited models a little bit more. So the unsolicited model is when the payer knows up front that additional documentation is going to be needed by the payer in order to process that claim or that service. So the provider is able to send that documentation at the same time they send the claim. So electronically, they're going to send the 275 at the same time that they send the 837. Just a note, X12 does allow the 275 to be sent in the same interchange as the 837, or you have the option to send the 275 in a separate interchange. From an NGS perspective, we only support the option for the 275 and the 837 to be in separate interchanges. We do not support it in the same interchange. The attachment control number is the main matching criteria that's used to link the 275 to the 837. In the unsolicited model, the provider assigns or defines that attachment control number. That attachment control number is included in the 837, and then it's also in the corresponding 275 transaction. So when we receive those two transactions, we're able to link the claim with the attachment documentation by using that attachment control number. For the solicited model, this is when the provider sends a claim to the payer. We receive that claim, we review the claim, and we determine we need additional information in order to process it for payment. So we request that information using the 277 request for additional information. Then the provider receives that, they're able to gather the information and respond by way of the 275 with the embedded HL7. Again, the attachment control number is used for matching, but in the solicited model, the payer assigns that attachment control number. And that attachment control number will be the claim control number. So it is sent in the 277, request for additional information. And then when the provider responds using that 275 transaction, they include the attachment control number in there. So when the payer receives it, they're able to link it to the appropriate claim. I'm going to turn it over to Sherry, and Sherry's going to talk through the unsolicited and solicited workflow examples for you.
Thank you. So I'm going to go ahead and click through. So from the provider, sends the 837. I want to stop here for just a minute. And in the attachment types, it could be HL7 C-CDA, 275 with the HL7 C-CDA. We'll talk in a moment about no attachments where the claim comes, or image. The point I want to make here as the clearinghouse solution, this could also, even be for fire support, but to provide that flexible technology solution, again, based on stakeholder EDI readiness, not only on the type of format, but also the methodology of delivery to be able to leverage this highway. So once we receive the attachment, we want to click through. The clearinghouse will then do the data normalization, format conversion, do file line level validation. And we also, the importance is we do apply attachment validation rules engine. So it's really important, we'll talk about that in just a moment, the rules of engagement. And then also the ability to match the claim to attachment. And we provided just some of the metadata that's used to match for attachment claim matching. Now, in that scenario, if you click through again, there is a scenario where we may receive a 837 without an attachment. So at that point, we applied our attachment validation engine rules. We stop, we pen the claim, and then we communicate the attachment request notification back to the provider. Again, based on stakeholder EDI readiness, the different formats and method of communication. From there, the provider returns. the attachment, the response types to us. Clicking through, the 837 goes to the payer and the 275 HL7 or the other type of attachments, and click through. And what's really important, based on payer workflow, attachments may come, the 837 may arrive first, or the attachment, again, based on payer specified timelines. So moving, next slide. So just a quick summary is the value of the clearinghouses, providing EDI conversion and routing, again, based on flexible technology solutions and EDI stakeholder readiness, regardless of the format or methodology of delivery. And also as part of this is the ability to have acknowledgement at every touch point of that attachment processing. So now let's take a look at the solicited model workflow. So here, the provider is sending the 837. Clearinghouse sends the 837 to the payer.
And then at the payer side,
go ahead.
When we receive that 837, if we determine that additional documentation is required, we will pen the claim. And then we communicate to the provider, this is the documentation that we need to process the claim. So we do send the 277 RFAI back to the provider.
And once we, as a clearinghouse, get that communication with that 277 RFI, we maintain, obviously, the metadata, and then we deliver the notification to the provider, again, based on their EDI readiness. And in that notification, that request has data that includes the link, the description on what type of attachments are required, the claims metadata, as well as the request expiration date upon receiving this, and the provider is returning the attachment. And from a clearinghouse point of view, providers don't need to necessarily know X12 or HL7. That's part of the functionality of clearinghouses, to be able to do that format and data normalization. Clicking through, we have that attachment normalization, format conversion, and then the transaction is sent to NGS with that 275 transaction and to the document management system and EDI gateway. So just a real quick, simple summary. Again, it's all about flexibility and technology solutions and stakeholder EDI readiness. The clearinghouses can do the EDI conversion and the routing, based on the capabilities across all stakeholders. And again, the ability to acknowledge at every touch point throughout the business process. So now let's turn it over and talk about success and lessons learned. Mary Lynn.
Thanks, Sherry. So I'm really excited to share these successes. I really feel that with our program, we've been in production for going on 10 years now. There's a lot of successes that have come out of our program. The first thing is we've improved the payment cycle for the providers. So the providers are reporting being paid for claims that require the documentation around 17 days versus 35 or more days with the manual process. Some of our providers are even reporting being paid up to 30 days sooner. So that's a big plus and win for the providers. Our EDI adoption ratio has definitely gone way up. So over the past 3 years, it has increased by 320%. So as you can see, every day, every week, every month, there's more and more providers, clearinghouses that are joining our program and participating. I thought that this was a pretty interesting measure as well to share with you. So 15% of our overall medical documentation that we receive, out of all the documentation we receive, is sent by way of the X12 275 with the embedded HL7. That does not include our portal. It is only the information that's coming through our EDI gateway, okay? So it's 15%. As this percent is increasing, we're starting to now see our paper, our fax, and our portal volumes decreasing. So I think that that's definitely a plus. The other thing that's pretty interesting is we did look at the average claim dollar amount for claims that require attachment. And what we found is they were between $3,000 and $4,000 on average. For claims that don't require attachment data, they were about $500. So as you can see, if the provider's getting paid up to 30 days sooner, and these claims are anywhere from $3,000 to $4,000, that's a big chunk of money. So that's a big plus for the provider. We're not holding on to their money for 30, 35, 40 days. As far as the 277 RFAI goes, we do expect it to decrease the response time simply, again, because they're receiving that electronic request the same day the letter is generated, but we are still measuring this due to some limited use. So the majority of our providers are sending their data in unsolicited. We do have providers who are enrolled in the 277 RFAI, but like I said, the majority of our information is coming in unsolicited. And I do want to add, I know that there's been a lot of concern over several years about payers receiving information that they don't need with that unsolicited model. We have not received anything in almost 10 years that we don't really need. So it has not been a problem. The providers know what data we need. We have it posted, they understand our policy, we've got our policies posted on our website, so they know when it's required, and they know if they send us documentation and it's not needed, it's going to delay their payment unnecessarily. So our providers are pretty good with that, and we haven't had any issues. So I do want to bring that up as well. Implementation timeframe. So when we implemented the unsolicited model, so this was the 275 with the embedded HL7, we were able to implement it in 6 months. Now, again, I know we're Medicare fee-for-service. We don't have several different plans like a lot of other payers do out there, so it's a little bit different for us. But I did want to note that we were able to implement it in production in about a 6-month period. We were able to prove that the X12 standard with the HL7 embedded works, and it works well. So that also has been a concern out there in the industry for many years. Like, how's this going to work? We don't have anything else like this implemented. So we were able to prove, yeah, we can do it. We take in that the 275 with the embedded HL7. We are able to process them, and we have virtually had no issues in almost 10 years. So I think that's saying something for the standard and for that approach. LOINC codes, we were able to prove that LOINC codes can be used to request documentation. So LOINC codes are new to payers, really, and I think providers from the perspective of requesting data. And we were able to prove that we can map all of our internal codes to a LOINC code, and we can put that information in the 277 request, and we can get the documentation we need back. So very good success measures that I did want to share with you. Now Sherry's going to talk a little bit about the clearinghouse successes.
Yeah, so we're also excited to share. This has been a long journey, and just want to share some of the highlights and stakeholders reported results. So percentage of denials due to missing attachments is the unsolicited model. They reported a reduction from 35% to 5%. Percentage of solicited requests due to missing attachments, a 25% reduction to 5%. Again, understanding those rules of engagement. But one of the most impressive findings we found was the percentage of appeals due to missing attachments reduced by 80%. Again, those rules of engagement and being able to increase first-time submission, getting it right the first time. The payment revenue cycle obviously helps with the providers in increasing attachment adoption. They reported 35 days reduced to 16. Payer status follow-up calls reduced by 75%. And then onboard provider timeframes. There are variables, of course, based on the attachment model and EDI readiness, but significant decrease over time as we have more engagement with these standards. An 83% reduction from weeks to days. And again, that comes from leveraging that existing IT connectivity and technology and workflow processes. In some cases, providers just need to add a payer ID and they can begin that implementation. In terms of EDI adoption ratio, we have to tell you, again, a long journey, but very exciting to see as the industry begins to pick up traction in this area based on the benefits and results. And today we're processing over 2.57 million T75s.
Okay.
So Mary Lynn, let's turn it back over to talk about the challenges.
Great. So with every implementation, you're going to have challenges, right? This is no different. We did have some challenges. So just want to share them with you and talk a little bit how we resolve the challenges. So defining the criteria for the unsolicited model was definitely a challenge. So we worked very closely with our operational and clinical staff. They helped us define the criteria and the situations where the documentation was needed, so providers could send it in unsolicited. And we have defined that criteria in our NGS companion guide that's available out on our website. The LOINC mapping was a bit of a challenge. Again, we worked with our clinical staff to try and help us match our internal messages up with LOINC codes, because of course the verbiage wasn't exactly the same. So they helped us with that. There were some LOINC codes that were not indicated as attachment LOINC codes. So we did work with the HL7 work group to have them added as an attachment LOINC code as appropriate. And where there wasn't a LOINC code available, we were able to request it. Again, going through the HL7 work group, that's the process that we followed. So that was how we resolved the LOINC mapping challenges. Now, the next one I think might be for some payers. We did have a lack of HL7 experience from a development perspective. And how we resolved that is we definitely participated in HL7, went to the work group meetings. You know, we were part of the attachment work group, and we were able to talk through some of our technical issues and figure out what the, how to resolve those technical issues. We attended HL7 educational webinars, so that was definitely very helpful. And plus, there's educational sessions, modules that you can take out on the HL7 website. They have also been very helpful. So I would just recommend that you get involved in HL7 to help resolve, if you have any issues with the lack of HL7 experience. Mapping the 277 from the paper letter. So there was some data content that wasn't available on the paper letters. Again, we did work with the shared systems to try to resolve that. And we did note some things in our companion guide, again, out on our website. Sherry, you want to talk a little bit about some of the clearinghouse challenges?
Sure, I have really 4 highlights I just want to touch on. We've talked a little bit about the early adoption challenge, the lack of critical mass being a barrier. And again, we were able, by validating stakeholder ROI was a critical key to begin to get traction. And that really comes from establishing key performance indicators, so you're able to measure your success and your outcomes. And the other important is stakeholder collaboration, really identifying those synergistic opportunities. And you saw from the previous slides how we're seeing other provider engagement, which is really exciting. And it's through that collaboration that I think we're seeing increase in traction with attachments. Stakeholder, the other one is interoperability. Due to lack of defined standards, and as you saw, there's various X12 attachment implementation versions, and also the challenge of stakeholders of prioritization on which payer model to implement. Am I doing unsolicited or solicited? Now, part of resolving that interoperability challenge is, again, clearinghouses provide that technology solution to provide the ability to do that data normalization format conversion, again, based on EDI readiness. And what's important, we're talking about X12. I saw an earlier comment go across the screen, but this can also be leveraged also for FHIR and other methodologies as well. The time to implement rules of engagement, this is an important challenge. We can't stress one of our solutions is working with payers, their payer companion guides. Those help define the rules to automate those workflow processes and allows us to apply upfront attachment edit requirements, and that significantly streamlines the process and accounts for some of the stakeholder reported results that we shared with you just a minute ago. In addition, I think one of the hardest challenges was organization buy-in. You really have to look at your enterprise workflow gap analysis, and that comes from your C-level, your development, your product, your marketing, your customer support. Working with those stakeholders was a critical component to be able to define what is your attachment model prioritization roadmap and where is that return on investment. Those are critical points. That leads us to the transition of the next slide, and that comes down to data analytics. So with this, cannot stress the importance of this. So in being able to build your attachment roadmap and to make those determinations of what models you're going to implement, you need to look at the type of services that require the attachment. What are your specific use cases, for your unsolicited and solicited, and how do you do that prioritization? The other is, what is the criteria for attachment, the rules of engagement? We can't stress the importance of being able to identify these points, prior to getting engaged, to make sure you're really leveraging the resources and your existing technology you have. And the other part is, what are your business opportunities? I'm going to turn that over to Mary Lynn to touch base on as a critical component.
Right. So the other part of this is the business opportunities, and the many benefits of the electronic process. Providers are paid so much sooner. The process is more efficient, and it reduces provider burden. So everything that we've kind of talked about here today, we're seeing more and more clearinghouses and providers enrolling in our program. Even though there isn't a regulation yet, the stakeholders are seeing the benefit and willing to make the necessary changes to help reduce the provider burden. They're really seeing the benefits, so they're going ahead and moving forward with that. With that, I think we are ready for the breakout sessions. So Michael or Rob, I think you were going to take it from here.